His chart said coma. The monitor said something else. The heart rate rose 6 beats the moment the man from Washington stepped into the ICU room. Most people in that room didn't notice. But when you've worked in intensive care long enough, small numbers can feel louder than alarms. My name is Dr. Teresa Vaughn. I'm 46 years old, and I've spent most of my career working nights in the ICU at St. Matthew Regional Medical Center in Norfolk, Virginia. Our hospital sits close enough to Naval Station Norfolk that we see a steady stream of sailors, pilots, and occasionally people whose job titles come with more stars than introductions. That night started like most ICU nights do. Quiet hallways, dim lights, the steady rhythm of ventilators and cardiac monitors, doing their mechanical version of breathing and thinking for people who can't do either one on their own. I was halfway through my coffee when the trauma pager went off. Level 1 transfer coming up, the charge nurse called from the desk. Within minutes, the elevator doors opened and a surgical transport team rolled a bed straight toward the ICU bay. The patient was already intubated, ventilator tubing, moving in slow, controlled breaths. Blood pressure line, IV pumps, portable monitor. The chart clipped to the rail had a name I recognized immediately: Vice Admiral Daniel Cross. Even in Norfolk, you don't see that rank in your ICU every day. The report from the surgical team was quick and clinical. Motor vehicle collision, single vehicle, rain-slick highway outside the city. Driver lost control and hit a concrete barrier. The vehicle took most of the damage on the front driver's side. Cross had gone straight from the emergency department to surgery for internal bleeding. Trauma surgeons stabilized him. CT scan showed a traumatic brain injury with swelling but no massive hemorrhage. Neurology had already written the working diagnosis: coma. The surgical resident finished the handoff and stepped back while we connected Cross to the ICU monitors. The ventilator switched over smoothly from transport mode. Numbers stabilized across the screen. Heart rate in the 70s. Blood pressure controlled. Oxygen saturation perfect. If you looked only at the monitor, you'd think he was sleeping in a very expensive hotel bed. But people in deep coma don't look that organized. The night neurologist, Dr. Ethan Cole, walked in a few minutes later. He did a quick neurological exam. Light in the pupils, pain stimulus, reflex checks, nothing dramatic. He stepped back and shrugged slightly. Deep coma presentation, he said. Not unusual with that kind of head injury, I nodded, but I kept watching the monitor. In ICU, medicine patterns matter more than single numbers. A patient's heart rate rises when you move them. Blood pressure shifts when they feel pain. Ventilator breaths drift slightly out of sync with the machine. The human body is messy. Cross's body was not messy. The ventilator delivered a breath. A moment later, the machine recorded a patient-triggered breath that matched the rhythm almost perfectly. That can happen. It wasn't proof of anything. But it was precise in a way that made me look up from the chart. Sedation level. I asked the nurse beside me. Minimal, she said. They kept it light after surgery for neurochecks. That meant his brain should have been capable of reacting unpredictably. But nothing on the monitor wandered. Dr. Cole finished his notes and headed for the door. We'll reassess in the morning, he said. Right now, the priority is controlling the swelling. That was a reasonable plan. ICU medicine is full of reasonable plans that eventually turn out to be wrong. About 20 minutes later, the hospital administrator appeared at the doorway with a man in a dark suit behind him. You could tell he wasn't hospital staff before he even spoke. The posture, the haircut, the way he scanned the room like he was evaluating security instead of a patient. Dr. Vaughn, the administrator said, lowering his voice slightly. This is Victor Halstead from Washington. Halstead nodded once. Department of Defense, he said. I was with Admiral Cross earlier today. That explained the midnight visit. Military cases sometimes come with people who ask careful questions and don't volunteer many answers. Halstead stepped closer to the bed. Is he aware of anything he asked? Not at the moment, I said. He's currently unresponsive. Halstead leaned slightly toward the Admiral, speaking quietly near his ear. I couldn't hear the words from where I stood near the medication pumps, but I could see the monitor. Heart rate 72, then 78. Not a spike, not panic, just a small controlled increase. The number held there for 3 seconds, then it slid calmly back to 72. I kept my face neutral and adjusted the IV line like I hadn't noticed anything. If you enjoy stories where something small turns out to mean everything, take a moment to comment below and subscribe to the channel. The cases that start quietly are usually the ones people remember the longest. Halstead straightened up. "Thank you, doctor," he said. He stayed in the room for another minute, watching the Admiral in silence, then turned and left with the administrator. The door closed. The ICU went back to its usual nighttime quiet. Ventilator breathing, monitor beeping, nurses typing notes into electronic charts. I looked back at the screen. 72 beats per minute, stable again. That could have been coincidence. ICU medicine is full of coincidences. Still, I leaned slightly closer to the bed rail and spoke quietly enough that only the ventilator could hear it. "Admiral Cross." I said, "If you can hear me, don't move." The ventilator delivered the next breath. For a moment, nothing changed. Then the monitor recorded a single patient-triggered breath that arrived a fraction of a second earlier than the machine expected. Just one. The number on the screen didn't jump. The rhythm returned immediately to normal. But that tiny adjustment was enough to make the back of my mind start working. People in coma don't usually follow instructions. I stood there for another minute studying the screen while the ventilator continued its slow mechanical breathing. Behind the glass wall of the ICU bay, the night staff moved through their routines like they always did. No alarms, no emergencies, just another patient in a quiet hospital room. At least that's what it looked like. But the more I watched the monitor, the more one thought kept pushing its way forward. Those numbers didn't look like the body of a man who was completely gone. They looked like the numbers of someone trying very carefully not to be noticed. The ventilator pushed out another slow breath while I kept my eyes on the monitor. Nothing dramatic happened. No alarms, no sudden drop in blood pressure, no frantic nurses running through the unit. Just numbers moving in quiet, steady rhythms the way they're supposed to. But steady isn't always normal. I stepped closer to the bed and checked the ventilator settings again. Assist control mode. Standard settings for a patient recovering from trauma surgery. The machine would deliver breaths at a fixed rhythm, but would also allow the patient to trigger additional breaths if the brain sent the signal. That earlier breath had been logged as patient-triggered. One breath doesn't mean much. The human body produces all kinds of noise when machines are helping it breathe. Still, I pulled up the ventilator history on the screen. A list of timestamps appeared. Most of them matched the machine's programmed rhythm. Except for one entry. Patient-triggered breath. The exact moment I had spoken. I looked at the Admiral's face. Daniel Cross lay motionless on the ICU bed, the ventilator tube secured in place. His eyes were closed. His skin had that pale tone patients get after surgery under bright hospital lights. If someone walked in and glanced quickly, they would see exactly what the chart said. A man in a coma. But ICU medicine teaches you something over time. It teaches you that the body leaks information constantly. Small signals. Changes in rhythm. Tiny reactions most people don't notice. The trick is knowing which ones matter. I checked his pupils again. Pen light. Left eye. Constricted normally. Right eye. Same response. That didn't prove anything. Pupillary reflex is controlled by the brainstem. Even patients in deep coma can still show it. I pressed gently against the nail bed of his right hand, applying a pain stimulus, the same way neurologists do during exams. The heart rate stayed at 72. Blood pressure steady. No visible movement. But that was also strange. Most unconscious patients show some kind of physiological reaction when you apply pain. Even if they don't move, the heart rate shifts slightly or blood pressure rises. Cross didn't do any of that. He stayed perfectly stable. I stepped back and glanced at the glass wall separating the ICU room from the central desk. The night shift looked exactly the same as it always did. Nurses reviewing labs, someone printing medication labels, a respiratory therapist walking past with a ventilator cart. Normal hospital noise. Nothing unusual. I pulled up the trauma notes from earlier that night. Vehicle collision. Rain. Single vehicle impact. I scrolled down to the police summary attached to the report. The driver had lost control on Interstate 64 just outside Norfolk. According to the onboard computer from the SUV, the brake pedal had been pressed fully in the seconds before the crash, but the vehicle never slowed. That detail had probably looked like a technical problem to whoever filed the report. To someone used to trauma cases, it was odd but not unheard of. Cars malfunction. Roads are wet. Drivers panic. But experienced drivers usually react instinctively. They steer. They swerve. They try something. The police note mentioned something else. No skid marks on the road. I closed the file and looked back at the Admiral. The ventilator delivered another breath. Then another. The machine beeped softly every few seconds. If he was aware of anything inside that body, there was no obvious sign. Dr. Ethan Cole came back into the ICU around 3 a.m. for another quick neurological check. He carried the tired look of someone who had already been called into the hospital once that night. "How's our Admiral doing?" he asked. "Stable," I said. Cole repeated the exam he had done earlier. Light in the eyes, reflex checks, pain stimulus. Nothing new. "Still unresponsive," he said, jotting notes into the tablet. "Not surprising this soon after surgery." I nodded. "Vitals look clean," he added, glancing at the monitor. "Very clean," I said. He looked at me briefly. "That bother you?" I shrugged slightly. "Most coma patients wander a little," I said. "These numbers look almost regulated." Cole studied the screen for a few seconds. "Could just be good sedation control," he said. "That's possible." He finished typing his notes and slid the tablet back into his coat pocket. "We'll see what things look like in the morning," he said. "Right now, the brain just needs time." That was the standard answer in neurology. Time. He left the room and the ICU settled again into its late-night rhythm. I pulled a stool closer to the bedside and opened the full monitor history. Every heartbeat recorded since the patient had arrived. The graph looked like a quiet ocean. Gentle waves rising and falling at predictable intervals. Then I spotted a tiny ripple. Around midnight. The moment Victor Halstead had leaned close to the bed. Heart rate climbed 6 beats. Held there for 3 seconds. Then returned smoothly to baseline. I leaned closer to the screen. Coincidences happen in medicine. They happen every day. But patterns are harder to ignore. I scrolled forward through the data. A second ripple appeared about 20 minutes later. Same pattern. Heart rate increase, then controlled, drop back to normal. I looked toward the door of the ICU room. Halstead had left long ago, but the timing of those changes was too precise to dismiss immediately. I checked the ventilator log again. 1 patient-triggered breath recorded during that same window. Most people in that room earlier probably assumed the monitor fluctuations were random. But random signals don't repeat themselves with the same shape. I stood up and stepped back to the bedside. "Admiral Cross," I said quietly, keeping my voice low enough that it wouldn't carry beyond the ventilator. The machine continued its slow mechanical breathing. "Your chart says you can't hear anything right now. No movement, no change. Which makes this a very strange conversation." I watched the monitor. Heart rate still 72. Blood pressure unchanged. Because if I'm wrong, I said I'm talking to a patient who's completely unconscious. The ventilator pushed another breath. The machine paused. Then recorded another patient-triggered breath arriving just slightly ahead of schedule. The number on the screen stayed calm. 72. No alarms, nothing dramatic. But that breath had come from somewhere other than the machine. And that meant the brain inside that motionless body might still be paying attention. I watched the ventilator log for another minute before touching anything else. The machine recorded breaths in clean, predictable lines. Mechanical breaths came at regular intervals. The patient-triggered ones appeared only when the ventilator detected effort from the patient's diaphragm. Right now, the Admiral's chart listed him as completely unresponsive, which meant that extra breath I had just seen shouldn't exist. I didn't say anything out loud. In the ICU, you learn quickly that announcing unusual theories before you have evidence is a great way to make everyone ignore you later. So I did the same thing most experienced doctors do when something feels off. I collected more data. I pulled up the full physiological monitor log from the central system and expanded the view across the last 3 hours. Every heartbeat appeared in a scrolling line across the screen. 72, 72, 71, 72. That pattern alone didn't prove anything. Plenty of healthy adults have heart rates that steady while sedated. But most trauma patients drift slightly. Their heart rate moves with small stimuli in the room, voices, lights repositioning. Cross's heart rhythm looked almost disciplined. The word crossed my mind before I could stop it. Disciplined. That made me glance again at the name on the chart. Vice Admiral Daniel Cross had spent decades in naval special warfare leadership. People who reach that level spend years training their bodies to stay calm under pressure most of us never see, which raised a strange possibility. If someone like that were conscious but unable to move, would their body still try to maintain control? I checked the ventilator waveform again. The machine pushed another breath into the lungs, then another. The waveform showed perfect mechanical delivery, no patient effort. Then the next cycle appeared slightly different. A small rise in the pressure line a fraction of a second earlier than the machine expected. Patient triggered, not dramatic, barely noticeable unless you were looking for it, but it was there. I leaned back slightly and crossed my arms. If this was random, it should disappear the moment I stopped paying attention. The ICU door opened behind me. One of the night nurses stepped in to check the IV pumps. "Everything okay?" she asked. "So far," I said. She glanced at the monitor, briefly saw stable numbers, and went back to adjusting the infusion line. That's the normal rhythm of hospital work. When numbers look calm, attention moves elsewhere. But I kept watching, because calm numbers can hide interesting things. When the nurse finished adjusting the pump, she stepped out again and the room returned to quiet. The ventilator breathed. The cardiac monitor kept its steady pace. I glanced at the hallway clock. 3:42 a.m. Night shifts in the ICU tend to blur together after a while. The building sleeps, but critical care never really slows down. That's when patterns become easier to notice. I opened the historical monitor data from earlier that night again and lined it up with the security access log for the ICU floor. The hospital records every badge swipe for security reasons. I didn't have direct access to the full system, but the nursing station keeps a simplified log for visitor tracking. I compared the timestamps. Victor Halstead entered the ICU floor at 12:08 a.m. Heart rate change recorded at 12:09. He entered the patient room at 12:10. Ventilator recorded a patient-triggered breath at 12:11. The heart rate returned to baseline at 12:12. I sat there for a moment without moving. One coincidence means nothing. Two coincidences start to look like a pattern. I pulled up the data from the second time Halstead visited earlier in the evening, before the surgical team finished handing off the case. Another small ripple. Heart rate increase. Ventilator adjustment. Then steady control again. The more I stared at the screen, the harder it became to ignore what those patterns suggested. Someone inside that body might be responding to the room. I turned my attention back to the Admiral. He hadn't moved. His chest rose and fell with the ventilator's mechanical rhythm. The bandage along his temple covered the surgical incision from earlier. His hands lay still at his sides. If someone walked in right now, they would see exactly what the chart described. Coma. But ICU doctors don't rely on appearances. We rely on physiology. I checked the sedation record again. Minimal sedation. The trauma team had intentionally kept medications low to allow neurological assessment. That meant the brain should be capable of generating signals, even weak ones. I stepped closer to the bed again. "Admiral Cross," I said quietly. No response. The ventilator delivered another breath. "You've probably spent most of your career being the person who notices things first." The monitor stayed steady, 72 beats per minute. But hospitals are full of people who notice things too. The ventilator hissed softly. I rested my hand on the bed rail and watched the waveform again. Right now, the entire chart says you're unconscious. Another breath. No change. Which means, if you're actually hearing any of this, I paused for a second. You're doing a very convincing job. The ventilator delivered another mechanical breath. Then the waveform twitched slightly. A patient-triggered breath. The machine accepted it automatically and continued its cycle. The numbers never changed enough to trigger an alarm. But that breath had come from somewhere. I exhaled slowly and glanced at the monitor history again. One extra breath might be noise. 2 might still be coincidence. But 3 began to look intentional. I checked the ICU hallway through the glass wall again. Still quiet. Still normal. The hospital administrator had said earlier that Victor Halstead would likely return during the day to check on the Admiral's condition. That thought lingered in my mind longer than it should have. Because if those monitor reactions had anything to do with Halstead's presence, there was only one way to test the theory. You wait until the same stimulus happens again. Then you see if the pattern repeats. I stepped back to the central monitor and marked the current timestamp in the chart. Not an accusation, just an observation. Physiologic responses noted during environmental stimulus. That's the safest way to write something unusual in a medical record. Neutral language. No conclusions. I returned to the bedside and watched the Admiral's chest rise and fall again. Machines kept breathing for him. Numbers stayed calm. But every so often, the ventilator log quietly recorded something the chart wasn't supposed to allow. And the more I watched those lines move across the screen, the more it started to look like the body of a man who wasn't completely gone at all. The ventilator logged another breath that arrived a fraction of a second ahead of the machine's schedule. I kept my eyes on the screen and didn't move. When something unusual appears in the ICU, the first rule is simple. Confirm it before reacting to it. The human brain is very good at seeing patterns that don't exist. Machines are less imaginative. So I watched the waveform. The pressure line rose with the ventilator cycle, then settled. No sudden changes, no alarms. The numbers looked calm enough that anyone passing the room would assume the patient was stable and asleep. But I had the ventilator log open beside the monitor, and the pattern had started to repeat itself just enough to make me careful. I stepped back from the bed and walked toward the central ICU desk. Night shift charting was in full swing. One nurse was reconciling medications. Another was reviewing lab values that had just come back from the night draw. No one looked concerned, which made sense. Cross's vitals were the most stable set of numbers in the entire unit. I logged into the hospital charting system and added a brief note. Observed intermittent patient-triggered breaths, despite minimal sedation and lack of voluntary motor response. No conclusions. Just data. The safest language in medicine is the language that leaves interpretation open. When I finished typing the charge, nurse glanced up. "Anything interesting with the Admiral?" she asked. "Stable," I said. That answer satisfied everyone within earshot. Stable patients rarely attract attention. The ICU lights dimmed slightly as the night cycle continued. Around 4 in the morning, the hospital takes on a particular kind of quiet. Not sleep exactly, but something close to it. I walked back into Cross's room. The ventilator breathed. The monitor showed the same steady rhythm. 72 beats per minute. Blood pressure normal. Oxygen saturation perfect. I looked at the Admiral again. The bandage along his temple was clean. No fresh bleeding. His face was still eyes closed, muscles relaxed in the loose way that follows heavy surgery. If he were aware of anything, there was no visible sign. Except the machines kept suggesting otherwise. At 5:18 a.m., the elevator doors opened down the hall. I noticed because the ICU floor rarely gets visitors before sunrise. Footsteps crossed the tile floor outside the unit. A moment later, the glass door opened and Victor Halstead stepped inside again. He was dressed the same way as earlier. Dark suit, military posture, the kind of expression people use when they expect to be listened to. The night clerk looked up from the desk. "Visiting hours start later this morning," she said politely. Halstead reached into his coat pocket and showed a badge. "Department of Defense," he said. The clerk hesitated for about 2 seconds, which is roughly the amount of time it takes hospital staff to decide whether they want to argue with someone carrying federal credentials. "Room 3, she said finally, gesturing toward the ICU bay. Halstead walked down the corridor and stopped outside the Admiral's room. I was already standing inside. He nodded once when he saw me. "Doctor." "Mr. Halstead." He stepped closer to the bed. "How is he stable?" I said again. That answer never gets old in a hospital. Halstead studied Cross's face for a few seconds. "The neurologist still believes he's in a coma. That's the current diagnosis." Halstead leaned slightly toward the Admiral, lowering his voice. "You always did have terrible timing, Daniel." The words were quiet, almost conversational. I couldn't hear everything he said, but the tone was unmistakably personal. At the same moment, the cardiac monitor shifted. 72. 78. The increase lasted exactly 3 seconds. Then the heart rate dropped back down. Halstead didn't notice. Or if he did, he didn't show it. He kept speaking softly near the Admiral's ear. The ventilator continued its slow rhythm. Then the waveform twitched. Patient-triggered breath. Logged automatically by the machine. I looked at the timestamp. 5:19 a.m. Exactly 1 minute after Halstead entered the room. The pattern had returned. Halstead straightened and looked at me again. "Is there any chance Hell regain consciousness soon? That depends on how the brain swelling evolves," I said. That wasn't my question. His tone stayed polite, but the wording was precise. "Neurology will reassess later today," I replied. He studied the monitor briefly. "Machines can keep a body alive for a long time," he said. "That's part of what they're designed for." He nodded slightly as if the answer confirmed something he already knew. "Keep me informed," he said. Then he turned and walked out of the room. The ICU door closed behind him. For a moment, everything looked exactly the same as before. The ventilator breathed. The monitor ticked along quietly. But the ventilator log had recorded another entry. Patient-triggered breath. I stepped closer to the screen again. 3 separate events now matched Halstead's presence in the room. That was enough to make coincidence a less comfortable explanation. I turned back toward the Admiral. "Admiral Cross," I said quietly. No response. "You might want to be careful." The ventilator delivered another breath. Because right now the only 2 people in this hospital who might be paying attention to those numbers, I watched the monitor. 72 beats per minute. "Are you and me?" The ventilator logged another normal cycle. Then the pressure line shifted slightly. Another patient-triggered breath. And this time the timing was so precise, it felt less like noise and more like an answer. The ventilator accepted the patient-triggered breath and continued its cycle like nothing unusual had happened. Machines in intensive care don't ask questions. They just record what the body does. I stood there for another moment watching the waveform settle back into its normal pattern. The monitor displayed the same steady rhythm it had held most of the night. 72 beats per minute. Calm. Controlled. Too controlled. I stepped out of the room and walked back toward the ICU desk where the night clerk was finishing chart entries. The early morning shift change was still an hour away, and the unit had settled into the quiet lull that usually comes just before sunrise. I opened the patient chart again and reviewed the trauma report from the beginning. Motor vehicle collision. Single vehicle. Rain. Impact with a concrete barrier. Those things happen every day across the country. Emergency departments see them constantly. But the details in Cross's report still felt strange. I scrolled down to the attached police summary again. The vehicle's onboard computer had recorded full brake pressure in the seconds before the crash, but the speed never dropped. That meant the driver had pressed the brake pedal, and the car hadn't responded. I leaned back slightly in the chair and read the line again. Brake pedal fully depressed. No reduction in speed. No skid marks on the road. For most drivers, that moment would trigger panic. Steering correction. Sudden swerving. Overcorrection. The kind of movements that leave marks on pavement. The report mentioned none of those, just a straight path into the barrier. I glanced back through the glass wall toward Cross's ICU room. The ventilator continued its slow rhythm, machines humming softly, a body lying still beneath hospital lights. If the crash had truly been unavoidable, then everything made sense. But if the brakes had failed in a way the driver could feel. A trained driver usually tries something, especially someone who had spent decades operating vehicles under stressful conditions. I opened another tab in the chart system and pulled up the emergency department intake note. Cross had arrived conscious but disoriented according to the paramedics. He had lost responsiveness shortly afterward during the trauma evaluation. That detail mattered, because it meant the brain injury likely progressed after the impact. Not instantly at the moment of the crash, which meant he had been awake long enough to understand what was happening in those final seconds behind the wheel. I closed the chart and walked back into the ICU room. The ventilator continued its steady breathing. Cross looked exactly the same as before. Unmoving. Silent. I pulled the stool closer to the bedside again. "Admiral Cross," I said quietly. No response. "I've been looking at the crash report. The monitor stayed steady. You pressed the brakes. 72 beats per minute. But the car didn't slow down. Nothing changed on the screen." That must have been an interesting moment. The ventilator delivered another breath. Then another. I leaned slightly closer, because a person who realizes their brakes don't work usually tries something else. The heart rate rose, not dramatically, 72 to 77. Then slowly back down again. I watched the number settle. There it was again. The same small controlled increase I had seen earlier when Halstead entered the room. I kept my voice calm. "You didn't swerve." The monitor remained steady. No skid marks. Another breath from the ventilator. That suggests one of two things. I rested my hand lightly on the bed rail. Either you never had time to react, or you decided not to. The heart rate climbed again. Just 4 beats this time, then settled. The ventilator logged another patient-triggered breath. I exhaled slowly. For someone who was supposedly unconscious, Cross's physiology was showing an unusual level of selective timing. I stood up and checked the ventilator display again. Assist control mode. Trigger sensitivity unchanged. The machine wasn't malfunctioning. It was doing exactly what it was designed to do, recording effort when the patient initiated it. I looked down at the Admiral again. "You've spent a long career in situations where people try to remove you from the equation," I said quietly. "No visible movement. Combat zones." The monitor stayed calm. Operations that probably don't show up in hospital charts. Another breath. The waveform shifted slightly again. Patient triggered. Which means you know something about surviving bad situations. 72 beats per minute. Perfectly stable again. I stepped back from the bed. The ICU hallway outside the room had begun to brighten slightly as morning approached. Nurses from the day shift would start arriving soon. Conversations would grow louder. More people would walk through the room, and small patterns would become harder to notice. I pulled the stool back toward the desk and opened the crash report one more time. The final line of the police summary caught my attention again. "Vehicle electronic systems under review for possible malfunction." That phrasing covered a lot of possibilities. But the more I looked at the data, the less it felt like a simple malfunction. If the brakes had failed electronically, the onboard computer might still record pedal pressure without translating it into stopping power. which meant the driver could have known something was wrong, known it seconds before impact. I glanced toward the ICU room again. Cross lay motionless, machines doing the breathing, numbers behaving almost too perfectly. I closed the report. If someone had interfered with that vehicle's braking system, investigators would eventually discover it. But investigations take time. And time inside a hospital room tends to move in quiet increments measured by machines. I walked back into the room and looked at the ventilator log again. Another entry appeared. Patient-triggered breath. The machine accepted it without complaint. I studied the waveform for another moment. Then I looked at the Admiral again. "If you realized those brakes were gone," I said quietly, "you had about 3 seconds to make a decision. The monitor didn't change. 3 seconds is not a long time, but it's long enough for someone with the right training to choose what happens next." I closed the crash report and watched the ventilator waveform settle again into its quiet mechanical rhythm. Morning light was beginning to leak through the ICU windows. The night shift had started its slow transition into the daytime routine. New nurses would arrive soon, fresh coffee in hand, ready to inherit the problems the night had uncovered. And the night had uncovered something. Not proof. Not yet. But enough questions that ignoring them would start to feel dishonest. I pulled the stool closer to the bedside again and looked at the Admiral. Daniel Cross still hadn't moved. His chest rose and fell under the ventilator's steady pressure. The surgical dressing along his temple remained clean, the IV lines stable, the monitors calm. If someone walked in right now, the chart would look reassuring. A patient resting quietly after trauma surgery. But quiet patients sometimes hide complicated problems. I checked the sedation record one more time. Minimal sedation. The neurology team had intentionally kept medication levels low to monitor neurological recovery, which meant the brain had the capacity to respond if it wanted to. I leaned closer to the bed. "Admiral Cross," I said quietly. The monitor stayed calm. 72 beats per minute. You may want to hear this part. Another breath from the ventilator. "I'm about to create a problem for someone. No movement. But I noticed the tiniest change in the waveform again. Patient-triggered breath. Logged automatically. I stepped back from the bed and walked toward the ICU workstation. The hospital charting system blinked open in front of me. I scrolled down to the neurological evaluation section and hovered the cursor over the note field. The official diagnosis still read the same. Severe traumatic brain injury. Coma. No voluntary motor response. Locked-in syndrome had not been considered. That line stayed in my head longer than it should have. Locked-in syndrome is rare. Most physicians will never see a true case during their career. It occurs when the brain remains conscious, but the body loses the ability to move or speak. Patients appear completely unresponsive, but they are aware, listening, trapped. It's one of the cruelest neurological conditions medicine knows, and because it's rare, it's often missed during early evaluations. I started typing. Observed intermittent ventilator-triggered respirations, inconsistent with expected coma presentation. I paused. Neutral language. Just data. Then I added another line. Physiologic responses observed during environmental stimuli, including visitor presence. Still neutral. Still careful. Finally, I wrote the sentence that mattered. Recommend evaluation for possible locked-in presentation before transfer or change in neurological status designation. I leaned back and read the note again. There were no accusations, no speculation about sabotage or politics, just a medical observation. But that one sentence had consequences. Hospital systems treat neurological diagnoses with extreme caution. Once locked-in syndrome enters the conversation, additional testing becomes mandatory. And mandatory testing means more eyes, more documentation, more people watching the case, which makes quiet decisions much harder to make. I signed the note and submitted it into the hospital record. The system timestamped the entry immediately. 6:12 a.m. I walked back into Cross's room. The ventilator continued its slow rhythm. Nothing on the monitors suggested anything had changed. But inside the hospital database, a small line of text now existed that hadn't been there an hour earlier. I pulled the stool back beside the bed. "Admiral Cross," I said quietly. No response. "Your chart just became more complicated." The heart monitor remained steady. 72. But if I'm right about what's happening here, the ventilator hissed softly. Someone else's morning just became a lot worse. A few minutes later, the ICU hallway grew louder as the day shift began arriving. Footsteps. Voices. The sound of fresh chart reports being printed. "Doctor, Ethan Cole returned just after 7 for the morning neurological check." He walked into the room holding his tablet and glanced briefly at the monitor. "Still stable?" he asked. "Yes." He stepped closer to the bed and repeated the standard neurological exam. Pupils. Pain stimulus. Reflex checks. No movement. Exactly the same result as before. Cole nodded and began entering notes into the tablet. Then he paused. His eyes moved slightly as he scrolled. "What's this?" he said. I leaned against the counter quietly. "My overnight note." He read the entry again. "Locked-in evaluation possible," I said. Cole looked back at the patient, then at the monitor, then back at me. "That's an unusual call this early," he said carefully. "Maybe," I replied. He studied the ventilator waveform for a few seconds. "Machines are honest in a way people sometimes aren't. They record things without interpretation." Cole looked back down at the chart again. "If that possibility exists," he said slowly, "we would need a full neurological reassessment. That's the recommendation." He exhaled through his nose and nodded once. "I'll notify neurology." He finished the chart entry and stepped out of the room. I stayed where I was. The ICU felt different now. Not dramatic, not chaotic, just slightly heavier. More attention, more eyes, which is exactly what complicated situations need. About 30 minutes later, the elevator doors opened again at the end of the hallway. I didn't need to look up from the monitor to know who had arrived. Victor Halstead walked through the ICU doors, carrying the same composed expression he had worn all night. But this time he walked straight toward the nurse's station. And the moment the clerk handed him the morning case summary, the calm expression on his face changed just slightly. Victor Halstead lowered the case summary slowly, the paper still in his hand. He didn't say anything at first. From where I stood near the monitor, I could see his eyes move across the page again. Hospital summaries are written in dry medical language. Most people skim them without paying attention. Halstead read every line. When he finished, he folded the paper once and looked toward the ICU room. Then he walked in. I didn't move away from the bedside. ICU staff don't usually leave when someone visits a critical patient. The machines still need supervision. Halstead stepped beside the bed and studied Daniel Cross for several seconds. The ventilator pushed another breath into the Admiral's lungs. Steady, predictable. "You've complicated things," Halstead said quietly. He wasn't speaking to me. The heart monitor remained at 72 beats per minute. Halstead placed the folded paper on the counter beside the bed. "A locked-in evaluation," he said, almost to himself. The tone wasn't angry. It was calculating. I kept my attention on the ventilator settings while listening. "That's an interesting development," he continued. The monitor stayed calm. 72. But unnecessary. He leaned slightly closer to Cross. "You should have accepted the outcome," he murmured. The words were soft enough that anyone standing outside the room would have missed them, but the cardiac monitor didn't miss anything. 72. 78. The rise lasted 2 seconds. Then the heart rate settled again. Halstead straightened slightly. "Still disciplined," he said. That word made me glance up. He had noticed it too. Halstead turned his head slightly toward me. "Doctor," he said politely. "Yes, you believe Admiral Cross may be conscious. I believe his physiology deserves further evaluation." That was the safest way to phrase it. Halstead nodded once. And if the evaluation confirms he is not conscious, then the record will reflect that. He held my gaze for a moment. You understand the implications of delaying a federal transfer. I understand the implications of missing a neurological diagnosis. The room stayed quiet for several seconds. The ventilator breathed. The monitor ticked along. Halstead turned back toward the Admiral. You always were stubborn, he said quietly. The heart rate climbed again. Not dramatically. 72 to 79. Then slowly returned to baseline. Halstead watched the monitor this time. His eyes narrowed slightly. Then he leaned closer to the bed. Daniel, he whispered. The ventilator delivered another breath. If you're hearing any of this, the monitor remained calm. You should understand the situation. Another breath. You lost the vote. The words were precise, political, meaningful to someone who understood the context. The heart rate rose again. 8 beats this time, then settled. Halstead smiled faintly. There it is, he said. He stepped back slightly. You always had trouble hiding your reactions. I kept my face neutral. The monitor displayed the same calm rhythm again. Halstead studied Cross's face for a moment longer. $5 billion, he said quietly. The words hung in the room. Defense infrastructure funding. The ventilator continued its mechanical breathing. You were planning to expose the contract irregularities. The heart rate rose again, 72 to 80, then back down. Halstead nodded slowly. Yes, he said. That sounds like you. I looked at the monitor history quietly. Each rise in heart rate appeared exactly when Halstead introduced a new piece of information. Controlled reactions, not random fluctuations. Halstead placed both hands on the bed rail. The crash should have ended this problem, he said softly. The ventilator hissed. But here we are. The heart rate climbed again, 10 beats this time, then slowly settled. Halstead watched the number carefully. Impressive, Ben, he said. You're still trying to control it. I spoke before he could continue. Mr. Halstead. He looked up. This is still a hospital room. Of course it is. Patients are entitled to medical privacy. Halstead smiled slightly. I'm sure they are. He straightened his jacket and stepped away from the bed. But he didn't leave the room yet. Instead, he walked slowly toward the window and looked out into the ICU hallway. Nurses moved between stations. Charts changed hands. Normal hospital life. When he turned back, the calm expression had returned to his face. You filed that neurological report very quickly, he said. I documented what I observed. Did you? The ventilator breathed again. Halstead walked back toward the bed. You should understand something, Doctor. I waited. National defense decisions are complicated. The monitor stayed calm. Medical decisions should remain medical. Agreed. He studied my face carefully. And yet you inserted yourself into a federal matter. I inserted a neurological observation into a medical chart. The room stayed quiet again. Halstead seemed to weigh something for a moment. Then he leaned down one last time toward the Admiral. You always did believe you could outweight people, he said quietly. The heart rate rose again, 72 to 82, then slowly returned. Halstead straightened. I suppose we'll see how long that strategy works this time. He turned toward the door. Before leaving, he glanced once more at the monitor, then at me. You've made an interesting morning, he said. And with that, Victor Halstead stepped out into the ICU corridor while the machines beside the bed continued recording every quiet reaction his words had just produced. The ICU door closed behind Victor Halstead with the same quiet click it always made. But the room felt different now. Not louder, not tense in an obvious way, just heavier, like the air itself had noticed something had shifted. I watched the heart monitor for another moment. The rhythm had returned to its usual pattern. 72 beats per minute. Perfectly controlled. The ventilator delivered another mechanical breath, then another. I leaned slightly closer to the monitor and replayed the last few minutes of waveform history. Each spike had matched Halstead's words with unsettling precision, which meant the next step couldn't be speculation anymore. It had to be testing. About 20 minutes later, the ICU desk phone rang. The charge nurse answered, listened for a moment, then looked toward me. "Neurology is setting up a remote consult," she said. I nodded once. Hospital protocol had already started moving. Locked-in syndrome may be rare, but once it appears in a medical record, specialists respond quickly. Missing that diagnosis carries legal and ethical consequences no hospital wants. By 9:10 a.m., the ICU lights were slightly brighter and a secure video monitor had been rolled into the room. Dr. Michael Reyes appeared on the screen from the Naval Medical Center across town. Reyes was a neurologist who had spent most of his career dealing with complex brain injuries. He studied the chart summary on his tablet while the camera showed the patient. "This is the Admiral," he said calmly. "Yes." Reyes looked directly at the monitor waveforms beside the bed. "Vitals look remarkably stable. That's part of the concern." He nodded slowly. "I read your note." I could hear hospital staff gathering quietly outside the glass wall. Nurses, residents, administrators. Situations like this draw attention. Reyes turned his focus back to the patient. If he is conscious but unable to move, he said, "We need a stimulus response test. Standard procedure. Nothing dramatic. Just controlled neurological prompts." I stepped beside the bed. The ventilator continued its rhythm. Reyes spoke from the screen. "Doctor, I want you to apply a cranial nerve stimulus behind the mastoid region." I nodded. That was the same nerve point I had used during the night. I placed 2 fingers gently behind the Admiral's ear. "If the patient is conscious," Reyes continued, "we may see subtle respiratory changes." I leaned closer. "Admiral Cross," I said evenly. The room went quiet. Even the ICU hallway noise faded as people leaned closer to the glass. "If you can hear me," I said, "I'm going to count to 3. The ventilator delivered a breath. 1. The monitor showed 72. 2. The ventilator hissed softly. 3. I applied light pressure to the nerve point. For a moment, nothing happened. The machine delivered another breath. Then the ventilator waveform shifted. A patient-triggered breath appeared. Reyes leaned slightly forward on the screen. "Repeat the stimulus," he said. I pressed again. "Admiral Cross," I said calmly, "if you hear me, try to change your breathing." 3 seconds passed. Then the ventilator logged another patient-triggered breath. The ICU room remained silent. Reyes nodded slowly. "That's interesting," he said. I could hear the charge nurse exhale behind me. Reyes spoke again. "Next test." He adjusted something on his screen. "Motor response attempt." That test was harder. Locked-in patients often retain minimal control over very small muscle groups, usually the eyes, sometimes a single finger. I stepped closer to the bedside. "Admiral Cross," I said. The ventilator breathed again. "If you can hear me, try to move 1 finger." Nothing changed. The monitor remained steady. 72. 5 seconds passed. 10. Reyes watched carefully from the screen. "Repeat the command," he said. I leaned closer. "Admiral Cross," I said quietly, "if you understand what I'm saying, move your right index finger." The ventilator delivered another breath. For a moment, the hand remained completely still against the hospital sheet. Then the finger moved. Barely. Less than a centimeter. But it moved with clear intention. The room froze. The nurse behind me whispered something under her breath. Reyes leaned forward in his chair. "Repeat the command." I nodded once. "Admiral Cross," I said calmly, "move your finger again." 3 seconds passed. The finger lifted again. Slow, controlled, not a reflex, not a spasm. A deliberate movement. Reyes sat back slightly. "That confirms voluntary motor control," he said. The ventilator continued its rhythm. The monitor climbed slightly, 72, 76, then settled again. Reyes spoke into the camera. "Admiral Cross, if you can hear me, attempt to open your eyes." Everyone in the room leaned forward slightly. Even the ICU staff outside the glass wall had gone completely silent. 5 seconds passed. Then the Admiral's eyelids moved. Slowly, deliberately. His eyes opened just enough to focus on the ceiling lights. The ventilator continued breathing. Reyes nodded once. "Admiral Cross," he said, "look toward the sound of my voice." The Admiral's eyes moved. Not randomly. They shifted directly toward the video monitor, toward the screen, toward the neurologist. The room erupted in quiet murmurs. No one expected the confirmation to be that clear. Reyes looked satisfied. "Diagnosis confirmed," he said calmly. "Locked-in syndrome with preserved consciousness." The ventilator breathed again. The Admiral's eyes moved slightly across the room. Then they stopped and settled directly on the man standing at the far end of the ICU corridor. Victor Halstead had returned, and for the first time since the crash, the man in the hospital bed was clearly looking straight at him. The Admiral's eyes stayed fixed on Victor Halstead. No one in the ICU spoke for several seconds. The ventilator continued its steady rhythm, pushing air into Cross's lungs with the same mechanical patience it had shown all night. The cardiac monitor ticked quietly beside the bed. 76 beats per minute, then slowly back down to 72. Dr. Reyes broke the silence from the video screen. "Admiral Cross," he said evenly, "we're going to run one more confirmation." The Admiral didn't blink. Reyes continued. "If you understand what I'm saying, look up once." The Admiral's eyes shifted toward the ceiling lights. "Now look back toward me." His gaze returned to the monitor. Reyes nodded slowly. "That's clear voluntary tracking." Behind me, one of the ICU nurses whispered, "Oh my God." But the moment of medical discovery quickly turned into something else, because the hospital administrator had already stepped away from the wall and picked up the phone at the nurse's station. Locked-in syndrome meant the Admiral had been conscious the entire time, which meant every conversation in this room might have been heard, including the ones Victor Halstead believed were private. Halstead was still standing in the hallway outside the glass. For the first time since I had met him, the confidence in his posture had faded. He looked at the Admiral, then at the cluster of doctors around the monitor, then at the administrator speaking urgently into the phone. He turned and began walking down the corridor. But he didn't get far. 2 hospital security officers stepped out from the elevator area just as he reached the hallway intersection. They didn't grab him. They didn't need to. They simply asked him to stop. Inside the ICU room, Dr. Reyes continued the neurological evaluation. "Admiral Cross," he said, "if you can hear me clearly, blink once." The Admiral blinked. "Blink twice if you understand that you are in the hospital." 2 blinks. Reyes leaned back in his chair, cognitive awareness intact. The ventilator continued breathing for him. Reyes turned to me on the screen. "You documented physiological responses during environmental stimulus." "Yes." He nodded. "That was a very important observation." Outside the glass wall, the hospital administrator had finished his call. When he returned to the room, his face looked tighter than before. "Pentagon investigators have been notified," he said quietly. That changed the atmosphere immediately. Medical cases move slowly. Federal investigations do not. Within 40 minutes, 2 vehicles pulled up outside the hospital entrance. I could see them through the ICU window overlooking the parking area. Dark sedans, government plates. 2 men in suits stepped out and walked quickly inside. They were escorted upstairs almost immediately. By the time they reached the ICU floor, Halstead was no longer standing in the hallway. Hospital security had moved him to a private conference room. The investigators entered the unit with calm efficiency. One of them introduced himself as Special Agent Daniel Whitaker. The other said very little. Whitaker stepped into the ICU room and studied the Admiral for a moment. "So he's conscious," he said. "Yes," I replied. "Has he spoken yet?" "Not yet. Motor control is extremely limited. Whitaker nodded. That's fine. He looked at the ventilator and then at the monitor. We only need confirmation that he's aware. Reyes spoke again through the video system. That confirmation has already been established. Whitaker stepped closer to the bed. Admiral Cross, he said calmly. The Admiral's eyes shifted toward him. If you can hear me, blink once. The Admiral blinked. Whitaker exhaled slowly. That's good enough. He turned to the second agent standing beside the door. Secure the hallway. The agent nodded and stepped outside. Whitaker looked back at me. You documented unusual physiological reactions during a visitor's presence. Yes. Was the visitor Victor Halstead? Yes. Whitaker nodded once. That matches what we were told. He glanced briefly toward the hallway where Halstead had been standing earlier. Admiral Cross had requested an internal investigation before the crash, Whitaker said, into what Whitaker's voice remained calm. A defense infrastructure contract. He paused. $5 billion. That number sounded familiar. Halstead had said the same thing earlier. Whitaker continued. Cross believed the contract process had been manipulated. The ventilator delivered another breath. Whitaker leaned slightly closer to the Admiral. Sir, if you understand what I'm about to say, blink once. The Admiral blinked. Whitaker spoke slowly. We believe your vehicle's braking system was electronically overridden. The heart monitor rose. 72, 78, then settled. Whitaker watched the reaction carefully. That confirms it. He straightened and turned toward the ICU staff gathered behind me. Forensic engineers have already recovered the vehicle. He paused. Preliminary analysis shows brake system commands were blocked by an external override. Electronic sabotage. Not a malfunction. Whitaker continued. Someone forced the vehicle to ignore the brake pedal input. The ventilator breathed again. The Admiral's eyes remained calm. Whitaker looked down at him again. You knew that before the crash, didn't you? The heart rate rose slightly, then settled again. Whitaker nodded slowly. That's what I thought. He stepped back from the bed. Admiral Cross didn't lose control of that vehicle, Whitaker said. He realized the brakes were gone. The ICU remained silent. Whitaker continued. And instead of trying to expose the sabotage immediately, he glanced at the Admiral again. He let the crash happen. The ventilator delivered another breath. Whitaker turned toward me. Because a dead admiral ends an investigation. He paused. But a living one forces the truth into the open. Whitaker walked toward the door. The good news, he said quietly, is that the evidence from that car is very clear. He looked back once more at the Admiral. And the man responsible just walked into this hospital believing you would never wake up. The ventilator released another slow breath as Special Agent Whitaker stepped out of the ICU room. No one rushed after him. No one needed to. Everything that mattered had already been set in motion. Inside the room, the machines continued their quiet work. The monitor displayed the same steady rhythm it had held most of the night. Nurses moved more carefully now, aware that the patient lying motionless in the bed was not unconscious at all. He had been listening. Doctor. Reyes remained on the video screen watching the Admiral's eye movements with clinical focus. Admiral Cross, he said calmly, we're going to attempt a limited speech test. The ventilator continued breathing. Your vocal cords may still function, but we need to confirm respiratory control first. I adjusted the ventilator settings, slightly reducing the support level just enough to allow the Admiral to initiate a breath on his own if he could. Admiral Reyes continued, try to breathe once without assistance. 3 seconds passed. Then the waveform changed. A shallow breath appeared on the ventilator screen, weaker than the machine's normal cycle, but clearly voluntary. Reyes nodded. Good. The ICU staff exchanged glances. That means partial respiratory control. He leaned slightly closer to his screen. Admiral Cross, if you can hear me clearly, try to form a word. For several seconds, nothing happened. Then the Admiral's throat moved. The ventilator recorded another patient-triggered breath. A rough sound escaped past the breathing tube. It wasn't a full word yet, more like the beginning of one. But it was unmistakably intentional. Reyes smiled slightly. "That's enough for now," he said. "Speech will improve once the ventilator support is reduced." He ended the remote session after confirming the neurological findings, and the screen went dark. The ICU room slowly returned to its normal rhythm. Machines, soft footsteps, quiet voices. But the meaning of the room had changed completely. The man in the bed was no longer a silent patient. He was a witness. 2 days later, the ventilator was removed. The Admiral's breathing had strengthened enough to function without the machine. His voice was still rough, and his body could barely move, but the locked-in paralysis had begun to ease slightly as the brain's swelling improved. The hospital kept security on the floor the entire time. Victor Halstead had been taken into federal custody before he ever left the building that morning. By the end of the week, forensic engineers had confirmed what the investigators suspected. The braking system in Cross's government SUV had been electronically overridden by malicious code inserted into the vehicle's control network. When the Admiral pressed the brake pedal, the onboard computer recorded the command, but the override blocked the signal before it reached the actual braking system. The vehicle never slowed. Halstead had arranged the sabotage through a defense contractor involved in the infrastructure project Cross had been investigating. The contract would have moved billions of dollars through a network of companies tied to Halstead's office. Cross had discovered the irregularities weeks earlier, and he had refused to approve the vote that would push the project forward. That refusal had created a problem. Halstead had attempted to remove the obstacle. What Halstead didn't understand was how people like Cross think under pressure. 3 days after the ventilator came out, I visited the Admiral during my afternoon rounds. He was sitting slightly upright in the hospital bed now, physical therapy equipment arranged around the room. His speech was slow but clear enough to understand. When I stepped inside, he looked up. "You noticed," he said quietly. His voice still sounded rough from the breathing tube. "Yes." He nodded once. I was hoping someone would. I pulled the chair closer to the bed. "You realize the brakes were gone?" "Yes." "How long before the impact?" 2 seconds, he said. I nodded. "That's not much time." "Enough." The room was quiet except for the monitor. I looked at him carefully. "You could have tried to swerve." "I considered it, but you didn't." He watched the monitor for a moment. If the crash looked suspicious, he said slowly, they would have buried the evidence immediately. I understood what he meant. "An accident," I said. "Yes." "A coma," he added. "Freezes everything." I nodded. Medical uncertainty forces investigations to slow down. Records remain open. Questions stay unanswered. He looked back at me. But I didn't know if anyone would notice. "You regulated your vital signs too well," I said. A faint smile appeared on his face. That was the idea. He rested his head back against the pillow. "Years of training." I crossed my arms. "Most soldiers forget they're connected to hospital monitors." He laughed quietly. Then the expression faded slightly. "You gave me time," he said. "I just followed the data." He studied me for a moment. "Where did you learn to watch people that closely?" I shrugged slightly. "Critical care medicine," I said. "That's where you learn the body always tells the truth." He nodded once. Outside the hospital room, reporters had already started gathering in the lobby downstairs. The story had begun to leak into the press. A sabotaged military vehicle, a defense contract investigation, an attempted assassination disguised as an accident. But inside the ICU, none of that noise mattered yet. The Admiral looked toward the window. "Halstead believed the crash solved his problem," he said, "and instead it created one." I stood up and adjusted the monitor leads. The numbers stayed calm. 72 beats per minute. Turns out I said the quietest patient in the hospital was the only one paying attention. The Admiral looked at the monitor beside him, then back at me. And for the first time since the night of the crash, the man who had pretended to be unconscious for 2 days allowed himself to relax completely, while the hospital machines continued recording the calm, steady rhythm of a body that had never actually stopped fighting. The ICU eventually returned to its usual rhythm. Hospitals are like that. Even after something extraordinary happens, the machines keep breathing, the monitors keep ticking, and the staff keeps moving from one patient to the next. Critical care doesn't pause for history, but some nights stay with you longer than others. What happened in that room wasn't just a medical case. It was a reminder of how much truth can hide in small details. In a hospital, doctors and nurses don't always solve mysteries with dramatic discoveries. Most of the time, it starts with something quiet. A number on a monitor that doesn't look right, a breathing pattern that feels too controlled, a patient who seems a little too still. Real hospital work often looks ordinary from the outside. But inside those rooms, every decision matters. Doctors and nurses are trained to notice the details most people overlook, because sometimes those details are the only voice a patient has. That night reminded me of something every doctor eventually learns: the body rarely lies. Machines record what happens whether anyone is paying attention or not. And sometimes the difference between missing the truth and uncovering it is simply choosing to look 1 second longer. Stories like this happen more often than people realize. Hospitals are full of moments where instinct training and patience come together. That's why so many of the most powerful doctors and nurses' stories come from real hospital floors, not from fiction. If you enjoy these kinds of real hospital stories, the mysteries, the human decisions, and the moments where medicine and truth collide, make sure you subscribe to the channel. There are many more doctors and nurses' stories from inside the hospital that most people never hear about. And sometimes the quietest patient in the room is the one who has the most to say.